Happy Sunday, everybody. We are glad to be back with you. It's been a little bit of a break. Tonight's a little bit different than what we had planned. One of our amazing hosts is currently dealing with some family issues. So you have Orva and I tonight, which is still a dream team, I think. And then we, the dream team, are joined by Dr. Akiko Shimamura and Dr. Cass Myers, who are the lead, I like to think of them as the lead hematology transplant doctors that tend to handle SDS. So when you get here, be sure you're commenting over on the chat that where you're joining from. We love to see where we're reaching. And we also love to see who's here, to see what's going on. And again, like always, the show is for you guys, so we want to know how best to help you. If you didn't get a chance to submit your hematology questions to us, you can type them in the chat and we will grab them as we go on with the doctors. The show is brought to you by the Shwachman-Diamond Syndrome Foundation, and it's made possible through them that this is happening, and it's for you guys. So welcome. Hi, Orva.
Yes.
How you doing?
Good. How are you?
I'm tired, but I'm good. I'm really good. Mostly tired.
I'm a lot tired. I'm right there with you.
I'm doing great. I feel like it's just been a weird week, and everything's going okay though, so that's good. And especially weird because Nicole's not here, which is also totally fine. But yeah, it'll be interesting. It's going to be great. So we are joined tonight, and we don't have any fancy polls or any giveaways because this is going to be a jam-packed hour with information. We have two amazing doctors who are both going to bring you as much information as they would give you at camp, which is the whole point of this, is that if we're not obviously able to be at camp right now, but we wanted camp to reach everybody. So this isn't exactly the same presentation you would get at camp, but it's a pretty good one. So should we get started? Do you want to? I see a couple people rolling in. Joan's here, Savannah's here, and I think there's a little bit of a delay, so I'm sure more people will keep rolling in.
I'm going to go ahead and bring the doctors. Dr. Shimamura disappeared.
Oh, she'll be back. It's fine.
I will bring on.
She'll find her way.
Thank you for joining us tonight.
There's a little bit of a delay, so I'm sure more people will keep rolling in.
I'm going to go ahead and Dr. Myers.
Oh, yes. Hello, everybody.
There we are. Hello.
Dr. Shimamura let me know she was having a little malfunction with her computer, so she was logging back out and in. So she should be back any minute.
Sounds fantastic. Do you want to introduce yourself to those who may not know you or who may not have met you at a previous camp or seen our previous SDSF Live?
Sure, absolutely. I'm Cass Myers. I'm one of the bone marrow transplant physicians and bone marrow failure doctors at Cincinnati Children's Hospital. And I co-direct the registry with Dr. Shimamura, who just popped up. Hey, Akiko. And I'm excited to talk to you guys about transplant for SDS today.
And Dr. Shimamura, do you want to introduce who you are to those who may not have seen you at camp or have been to see you as a doctor or any other time where they would have met you?
Certainly. So I'm so sad that we're unable to get together in person at camp. We all look forward to that, but this is the next best thing. And a huge thanks to SDS Foundation and to Orva and Michelle and Nicole for hosting this. So thanks for the invitation. So I'm Akiko Shimamura. I am a pediatric hematologist over at Dana-Farber and Boston Children's Hospital in Boston. And I direct the bone marrow failure and MDS program more on the non-transplant side. I'm also a physician scientist, so I run a laboratory and work on Shwachman-Diamond syndrome in the lab, as well as in the clinic.
I love that we have such a powerhouse of doctors like at our fingertips. It's really, I know for me and my family, it's comforting. And I know for multiple other families, we all feel a lot more comfortable that there's actually people who invest a whole lot of time into just SDS. And not that everything else isn't important, but always comforting, especially when it's such a weird disease. So I don't know. I think Dr. Shimamura, you had to give your presentation first, correct? Okay.
After the first 30 minutes. Am I unmuted? Yep.
You're unmuted.
So let me see if I can share. Shall I try to share my screen now?
Yeah,
All right,
let's.
Down.
Let me see if I can do this. Let's see. All right. Is that showing up?
It might be. Orva, do you want, can you do that fancy thing where you make her screen big and Dr. S small in the corner of it? Yes, with your fanciness. I don't see the screen yet. However, when you go to click share screen, if you click the application window, I don't know what you're sharing it from, but sometimes you have to click the second part of it.
Let's see, screen one. All right, so it's going to share my whole screen, but I think that'll be okay. All right, so I'll do that. Can you see it?
We can, as long as you maximize it to the screen or hit show presentation or.
Did that work?
The screen is now black. There we go. You did it.
Can you see the slide?
Yes.
Okay. I'm unable to, because it's taking up my whole screen, I'm unable now, because it's more important that everyone see the slide. Let me just try. Let me see if I can move it to, no, can't. All right, so we'll just proceed like this, shall we? And sort of see how it goes.
Sounds good.
Okay, so I'm going to start off for the first half of this hour by talking about the hematologic complications in SDS, and then Kaz will talk about bone marrow transplant. So I'm hoping to leave enough time at the end for some questions. I think that's an important part of these sessions, so I'll try to get through everything. And I kept this fairly pared down. So just for those who either missed Dr. Alter's Hematology 101 session or anybody who's new to SDS, I just wanted to take a few minutes just to review some of the vocabulary that we use when we talk about blood complications in SDS. So we talk about low blood counts. So the neutrophils, which are the cells that fight infection, if they're low, there is an increased, of course, susceptibility to infection. The platelets are important to clot your blood. So if the platelet count is low, there's an increased risk of bleeding. And then low red cells cause anemia. And red cells are important to transport oxygen throughout the body. So if you don't get enough oxygen to your body, you feel very tired, you can get short of breath, you can't do standard activities sometimes without getting really winded, you can be dizzy, sometimes growth can be poor. It's basically the body's not being oxygenated well. And the reason that blood counts are low in SDS is because the bone marrow cannot produce the blood cells. So on the left here, you see a healthy bone marrow, and you can see those big pink areas are the bony trabeculae. There's sort of bony bones running through, little bony areas running through your marrow. And in between these bony trabeculae are the blood cells. So those are all those little dots, right? And instead, if you look on the right, now you still see the bony trabeculae, right? You see that big pink splotch, but all those dots of cells are gone. All those blood-producing cells have disappeared. And that's what happens in Shwachman-Diamond syndrome. We get bone marrow failure leading to low blood counts. A couple of other definitions. What is myelodysplastic syndrome, or MDS? MDS is a pre-leukemic condition caused by development of abnormal blood cells. And this manifests clinically by low blood counts, together with an abnormal appearance of the blood cells in the bone marrow. Well, you'll hear us refer to them as dysplastic, meaning their appearance is abnormal. Sometimes the chromosomes develop abnormalities in the blood cells. And sometimes when we look in the genes in the blood cells, they've acquired abnormal mutations. And we'll talk more about that later in the talk. Lastly, what is leukemia? So the leukemias that typically develop in Shwachman-Diamond syndrome are the acute myeloid leukemias, or AML. Leukemia is basically a cancer of the white blood cells. And this is where these cells become abnormal and they don't know how to stop growing. They just have uncontrolled growth, but they can't mature. So they're these sort of immature, abnormal cells that just grow and grow and grow and take over the bone marrow. And they suppress the ability of the normal blood cells to grow. So they kind of take over the bone marrow and sometimes other parts of the body as well. So it's a cancer. So, when do we think about treatment? And we have a couple of treatments in our back pocket, and so I'll just allude to a couple. So GCSF is an injection given under the skin with a little teeny weeny needle, and it can stimulate development, it can stimulate production of the neutrophils. We usually reserve this for patients who have what we call symptomatic neutropenia, meaning they're neutropenic and they're running into clinical trouble because of that. So they're either having recurrent infections or very serious infections. Even a single serious infection may warrant subsequent treatment with GCSF. We do not generally treat based solely on the neutrophil count, but again, this needs to be individualized. But people ask, what is the cutoff for a neutrophil count at which you treat with GCSF? And in Shwachman-Diamond syndrome, we don't necessarily treat based on the neutrophil count alone. Okay. Bone marrow transplant, which Dr. Myers will talk about, is reserved for people with very severely low blood counts that cause symptoms, that cause problems. Either they require transfusions or they cause infections or bleeding. And of course, MDS or AML, the treatment of choice, is a bone marrow transplant. So I'll leave that discussion for the second half of this. Now, why do we focus on blood problems in SDS? So it's important to remember that blood problems in SDS are treated differently from these blood problems if they arise in people who don't have SDS. The standard treatments that we use in non-SDS patients either don't work in SDS or they're too toxic in SDS. And so we have to modify the treatments. You can't just extrapolate from how we treat blood problems in non-SDS patients. And I would say that this is different from almost all the other complications that develop in SDS. Most of the other complications in SDS are treated the same way in SDS as they are in non-SDS patients. So the exocrine pancreas issues are treated with enzymes just as they are in non-SDS patients. Behavioral issues, neurocognitive issues are evaluated and treated the same way that they are in non-SDS patients, and so on. But the blood problems are different. So some of the questions that we're trying to grapple with, and one of the leading reasons that we started the registry in the first place, are to answer these types of questions. So how many patients with SDS will develop severe complications of bone marrow failure, MDS, or leukemia? We don't know how many patients will ever develop this in their lifetime. Is it the majority? Is it a minority? Is it only a subset? Can we predict who is going to develop these complications? Who's going to develop severe marrow failure, MDS, or leukemia? If we could predict who's at high risk, we could do more intensive surveillance for those patients, but maybe not so intense surveillance for others. And we could intervene early when treatments are most likely to be successful. How serious are these complications anyway? How do people do once they develop these complications? And what are the best treatments for bone marrow failure, MDS, or leukemia? And again, I wanted to stress that the standard treatments used in non-SDS patients are not necessarily the best treatments to be used in patients with SDS. They require some tailoring and modification. So far, I've given you a bit of a review. For those of you who are aficionados in the field, I also wanted to present some cutting edge data that's coming out of the registry that I think will be helpful for you to hear about. So in addition to this brief review, I wanted to talk about a little of the blood complications as an update from the Shwachman-Diamond syndrome registry. And Elissa Furatani, who has joined Kaz and I in working on the registry. She's a young investigator, clinical investigator. She will be talking in another SDS Live talk in a few weeks in more detail about the blood complications and what we're finding in the Shwachman-Diamond syndrome registry. But I'm just going to give you a little taste of that now. So what we found is that severe bone marrow failure, that's severe enough to require transplant, generally we're seeing in the younger patients. We don't really see this developing so much in older patients. It tends to happen young. And this is consistent with what has been reported in the French SDS registry. So of the 8 patients in our registry who required a transplant for severe bone marrow failure, 6 of the 8 were transplanted prior to the age of 2.5 years of age. So they're really quite young. Half the patients transplanted for bone marrow failure were less than age 1.7 years, and half were older. And the range that we saw was 0.4 years, so just a few months, all the way out to there were some adults who still required transplant for bone marrow failure. The oldest is 39, over 39 years of age. But for the most part, bone marrow failure is primarily a issue in the younger patients. Doesn't mean it can't happen in older patients, but it's more common in the younger patients. In contrast, MDS and AML tend to occur, they can occur young, but it continues to accrue as patients age. And MDS and leukemia is actually the leading cause of mortality. In our registry, 80% of mortality was due to MDS or AML. It was not from infections. It was not from other issues. Bone marrow failure actually, as a cause of mortality, was actually very, very low. There were only 2 patients who had problems with bone marrow failure and didn't survive. Now, I want to warn everybody that this next part of my talk is going to be tough to hear. This is a very difficult problem, the serious blood problems that we grapple with, and it's sobering. So I just want to warn you that this next part is going to be tough to get through. But we need to understand this in order to beat it. And I want to tell you what we're doing to beat these blood problems in Shwachman-Diamond syndrome and give you some hope at the end with some of the new things that we're learning in the registry, right? So, all right, so this is the tough part. So this is a study that we did. Kaz Myers led this together with Alyssa Furtani and myself. And Edie Weller, I just want to put a shout out to our amazing biostatistician who really did a very rigorous analysis of the data from 36 SDS patients with MDS or AML. And we partnered with colleagues, you'll see them all listed here, from around the country, and even colleagues in Canada from 18 institutions to try to understand what's going on with MDS and AML. And we realized that the reason that we wanted to do this study is we really did not understand how MDS or AML presented in patients with SDS. The definitions of MDS and AML have evolved. They've really changed over the past few years, so we cannot necessarily extrapolate from old publications because they used a different definition of MDS and AML. So we wanted to use modern definitions of MDS and AML. We don't know how to treat MDS and AML in Shwachman-Diamond syndrome, and indeed, most papers just lump them all together. They treat them as though they're the same thing, and they're not. They are different biological and clinical entities. And we also don't know the optimal surveillance strategies for MDS and AML. So when we looked at survival of patients with SDS who developed MDS or AML, you can see that with MDS, the outcome was a little bit better, but still sobering, that half the patients survived less than 7.7 years and half survived longer than 7.7 years. So that's what median survival means. As you can see, AML was a much more serious disease. You can see that there's a rapid mortality within the first year of life, first year of diagnosis with AML, and there are very, very few survivors. As a matter of fact, there was only a single survivor out past 2.5 years. This is AML at presentation. There were 2 patients who started with MDS and it evolved into AML. So why are these patients doing so badly? Well, there were 2 reasons why they're doing badly. One, patients were doing badly because the treatments were too toxic. So if you use standard treatments for MDS or AML, patients with SDS don't tolerate it well and they died of toxicity. The other problem was if they survived the treatment, they passed away because of resistant disease. The disease either didn't go away or it went into remission, but then it relapsed, right? So the disease is not, that our current treatments are not effective against leukemia and Shwachman-Diamond syndrome. So what we realize is we need better treatments, and we need also a better way to identify patients before they develop MDS or AML, right? We want to catch them before they develop these complications because we know our cure rates are pretty good if we can transplant them before these develop. And Kaz will talk more about transplant outcomes in the non-MDS AML patients. So that made us focus on surveillance in an effort to identify patients prior to leukemia development. So we queried in these 36 patients how that was going. And what we found was only a small subset of patients were, only partial, about half of patients were actually getting any kind of surveillance. A lot of patients had no surveillance. And the major reason that I heard about was they were doing well. They looked well. Their blood counts were not that low. And so there was a sense of things going well, and there wasn't a urgency to look for impending signs of leukemia. So one of the important things we learned is just because your disease looks mild doesn't mean that you're not at risk for leukemia. You cannot let up your guard, right? So that was an important lesson from this. We didn't know that before, right? We also learned that blood counts are not a sensitive predictor of leukemia. So you don't always get a warning by just monitoring blood counts that leukemia is impending, right? The blood counts don't always, sometimes the blood counts don't drop until the leukemia has developed. So by the time the blood counts drop, it's too late. So we really need better tests. So what are we currently doing for surveillance? So we do, of course, look at blood counts. I mean, it can give you some hint, but not, it's alone, it's not enough. So we also do annual bone marrow exams, right? That's the recommendation, annual bone marrow exams. We look at how the cells appear under the microscope. We look at the chromosomes, the cytogenetics. We also look at the chromosomes using this very sensitive fluorescent test, FISH, which I think Dr. Alter talked about. We look at flow cytometry, which is we color code sort of how the different protein markers on the surfaces of our blood cells look. And now in the modern era, we're doing sequencing. We're sequencing for genetic alterations that might give us a hint that MDS is impending. But as with any new technology, the technology advances before our understanding of what to do with it does. And this is a good example. So in collaboration with Dan Link, Kaz Myers and I in the registry, as well as others, worked with Dr. Link to study mutations in SDS. And what Dr. Link found was that mutations in P53, the gene is called TP53, the protein is P53, are common even in patients who do not have MDS or AML. So patients with Shwachman-Diamond syndrome frequently develop P53 mutations. But we had no idea what this means. So we know that P53 is a scary gene. It is associated with malignancy, but we didn't know what it meant in Shwachman-Diamond syndrome patients. And based on this paper, a lot of doctors were inclined to take Shwachman-Diamond syndrome patients to transplant. But frankly, this paper doesn't say that. It doesn't say that patients with TP53 mutations need to go to transplant. It just says that these patients commonly have these mutations. So in order to understand this better, we looked in a lot more depth in Shwachman-Diamond syndrome through the registry. And this was in collaboration with Coleman Lindsley and Alyssa Kennedy. Coleman Lindsley is a very talented investigator who is an expert in MDS and AML and looking at the genomic sequencing in these disorders. Alyssa Kennedy is a young investigator working in my lab, and I have two research assistants, Gwen Moscato and Kiki Bellotti, who did a lot of the work on this as well. And I wanted to thank, we submitted a paper and we've dedicated to all of you in the registry who have donated your samples, who have donated clinical data for these many years. I know it was rough going because it took a long time to get enough data to be able to say anything useful about. So a huge thanks to all of you. It's because of you that we've learned what we were able to learn. So this is what we've learned. We've learned that mutations in EIF6 and P53 are very common in Shwachman-Diamond syndrome. So this is, each column is a separate patient, okay? And each row is a gene, right? And this is their clinical status. So these are patients with AML. These are patients who developed MDS. These are patients who did not develop MDS or AML, nor did they have severe marrow failure, defined as marrow failure requiring transplant. And what you can see is people with MDS or AML, certainly everybody with AML had P53 mutations. Some people with MDS had P53 mutations. And a lot of people without severe marrow failure or MDS or AML had P53 mutations, right? You can see that the patients with severe marrow failure actually didn't have any mutations. You can see that EIF6 is also very common, both in patients with leukemia, MDS, as well as no severe marrow failure. And this was actually also very interesting. So we also queried a series of patients who have SDS, what we call SDS-like disorders. You've got clinical features of SDS, but we can't find a gene. We couldn't find SBDS, EFL1, SRP54, or DNA-JC21. None of the known SDS genes were found. And we were very relieved to see that none of these patients so far in the registry have developed MDS or AML, and they actually didn't have any mutations in any of these genes. So these patients appear to be clinically and biologically distinct from those patients with SBDS mutations, okay? So why do we care about P53? So I'm sorry, I have to wrap this up. So P53 is the guardian of the genome. So as you can see, a happy cell in your bone marrow is happily dividing and making new cells, producing blood cells. But what happens is if your bone marrow undergoes stress or damage, the cell sustains damage, the P53 will activate checkpoints to first tell the cell to, stop growing. So it'll tell it to arrest, stop growing, you've got damage, right? And sometimes it will also tell the cell, you know what, you are so damaged, we need to get rid of you. You're going to cause problems, such as cancer. So you need to go away. So it triggers the cell to self-destruct. So it's a way for the body to monitor for damaged cells and get rid of them, right? So if you're lacking P53, you can't get rid of these damaged cells. And so we were trying to understand what is it, because a lot of patients have P53 mutations, but have not developed leukemia or MDS, at least not yet, right? And we followed these patients for many, many years. So what we found is the number of P53 mutations was not helpful. That was not predictive of leukemia risk. It's not that the more P53 mutations you have, the higher your leukemia risk. Let's look at the type of P53 mutations. Does that make a difference? Nope, did not predict leukemia. Let's look at the size of the P53 mutant cells. Maybe you have a very large percentage of P53 mutant cells. Maybe that predicts leukemia. No, that didn't either. Let's look at the growth of the mutant clones. So maybe these cells, if you follow them over time, if they start to expand, maybe that predicts leukemia. Nope. What we found was these P53 mutant clones tended to persist for years and years and years and years and years, but at a very low frequency. They were often very small populations, right? So that was not helpful. The only thing that correlated with leukemia risk came from insights of single cell sequencing. So normally when sequencing is done as a clinical test, many of you are having this done on your mares as a clinical test, the bone marrow cells are in a test tube and the whole gamish of cells are sequenced. And what we can tell you is 25, I'm just making this up, 25% of mutations were, there were P53 mutations in 25% of this population and EIF6 mutations in 25%, right? But that doesn't tell you how they're arranged. So what we did was single cell sequencing. And what single cell sequencing can distinguish is whether the, number one, are the P53 mutations shown in red and the EIF6 mutations shown in purple happening in the same cells, or are they happening in different cells, right? And what we found when we did single cell RNA sequencing, meaning we sequence individual little cells, this is a situation that we see in Shwachman-Diamond syndrome patients. We see populations of cells that have P53 mutations and separate populations of cells that have EIF6 mutations. When we looked in leukemia, we never saw this though. We never saw a situation where there was a single P53 mutation. Remember, every cell has 2 copies of the P53 gene, right? One inherited from mom, one inherited from dad. So we've got 2 copies of this gene. And what happens in leukemia is that what a cell will acquire 2 mutations. So a cell that originally had 1 mutation now takes a hit to the second copy of P53. And this cell then grows out into leukemia. We never saw leukemia cells growing out from EIF6 mutant cells, right? It actually appears to be protective in a sense against leukemia. But once a cell develops this, there appears to be a risk of going on to leukemia. So we're very interested in now incorporating single cell sequencing into our surveillance strategy, right? So this is just our summary. P53 mutations are common in SDS without MDS. This is very important because, again, don't go to transplant just because you have a P53 mutation. That's not an indication for transplant right now because these mutations can persist for years without progression. But if you see 2 mutations coexisting in a cell, that is a warning sign, and that is an opportunity for intervention right there. And again, cells with EIF6 mutations did not progress to leukemia, but it didn't prevent other cells that don't have EIF6 mutations from progressing. So for those of you who are enrolled in the registry, we have a grant now, which for the next few years will allow us to offer you genomic sequencing. So you can order it as a clinical test, which is best. If you're able to order it as a clinical test, you should do that because it's covered by insurance and you'll get the result quickly. We can run it as a research sample. It's not as fast. We can't get the result to you as fast, but we can do it and we can return the results to your doctor. The other thing that we can do that is not available clinically is single cell sequencing. And we can give back to you whether we're seeing 2 P53 mutations arising in a single cell, because that would be a worrisome finding that you would want to discuss with your doctor. The more samples we receive, the faster and less expensive the runs are. So we have to batch because it's research and we don't have a lot of money for this. So we have to batch the samples. So the more samples we get, the faster we can run them. So if you have any questions about that, feel free to contact the registry. And I just wanted to acknowledge everybody in my lab. I tried to acknowledge everyone as we were going through this. A special shout out to my partner, Kaz Myers, as well as Stella Davies at Cincinnati Children's. They were close partners in this whole project, as well as Coleman Lindsley, my clinical research team, Maggie Malsh and Ashley Galvin, who many of you know, are biostatisticians and our funding agencies. So with that, I'd like to stop and if there's time, take a few questions. So I have to stop sharing my screen. How do I do that? Let's see. Sorry.
We see it. We don't see your screen anymore.
Okay. Okay.
So we had a couple of questions roll in, and they might have been answered. But one of them was, what genetic tests would show if the patients had a P53 mutation?
Yes. So it's most sensitive in the marrow, we think, but we're currently looking to see whether we can actually run surveillance in blood. I mean, wouldn't it be great if we didn't have to do all this marrow surveillance all the time, and if we could run surveillance with blood? And so we're currently gearing at COVID. Our labs had to shut down during COVID, but we're up and running again, and we're on the verge of sending out blood. So many of you were very kind enough to send not only marrow samples, but blood samples at the same time. And so for those of you who did that, we're able to run your blood samples and look to see what we see by sequencing. So that's something that we'll look at. But right now, I recommend that you do this in marrow because we haven't validated whether it's sensitive in blood. Now, that's an important point because if you talk to our adult colleagues, in adult MDS, blood is just as sensitive as marrow. I mean, that's been shown. And because of that, a lot of people are saying to us, why do you bother doing marrow? And my answer to that is the marrows in Shwachman-Diamond syndrome are very empty, right? It's not like adult MDS where the marrow is packed with MDS cells. We have empty marrow. So I don't know in the setting of an empty marrow whether the blood is as sensitive, right? Because there's not as much material there. So I don't think we can extrapolate based on the adult data. We need to test to make sure.
Joan had asked, what can damage a cell or cause stress to the cell?
So that's a good question. So in healthy people, there's something called replicative stress, or with the stress of aging, there are hits that a cell takes that causes, as we age, us to naturally accumulate mutations. That's just a natural part of aging. It's very rare, though, in healthy children to see mutations in the bone marrow. You really don't see it in healthy children. In contrast, in Shwachman-Diamond syndrome, we're seeing all these mutations. And what we found, and I didn't have time to go into this, but I'm happy to talk offline with people, is the ribosomal stress that's been set up by this SBDS mutation. That is the stressor that is causing the cell to try to compensate. And we believe that this is driving, because of the ribosomal stress, these mutations in EIF6 and some of these other mutations, as well as P53.
Interesting. Science is so big. Science is so big. And I loved hearing all of the updates to the registry and what you guys are able to offer now. And I think the registry, I know it's not a registry SDS lab, but it's very important that if you're not on the registry, to get on the registry. It's a powerhouse of information and knowledge that's available. That's only helping, SDS in the future.
We're so excited to have this opportunity, hopefully, to give back information, the marrow single-cell sequencing for those of you who are participating, so that you will get that back. Not in real time, unfortunately. It's not a clinical test, but hopefully fast enough so that it will be helpful to you. The other thing that I wanted to say is this recognition that ribosomal stress appears to be driving these acquired mutations offers us a potential therapeutic opportunity, right? If we can ameliorate this ribosomal stress, maybe we can relieve the pressure that's driving these mutations. And so we're working on different strategies to try to ameliorate this. And so that's another area that, we really are interested in, not only leukemia treatment, but leukemia prevention. And I think there's opportunities there.
What's the easiest way for someone who would want to get in contact with the registry to maybe inquire about this P53 or any other information that you had said to check into for them?
Yes. So anybody who's interested in learning about the registry and what we're doing can call the registry. We're setting up a new website. We've mocked it up, so hopefully it will go live soon. But even the old one will have our contact information. If you just email us or call us, Kaz or I are happy to talk with you about any of this.
Sounds great. Thank you so much for your talk, Dr. Shimamura. It was very, very helpful for anyone who not only maybe is very new to SDS and might not know the hematology background, but as well as the families who have been around a while. We really appreciate it.
Thank you so much. And I'm sorry I can't stay. Dr. Myers, I know you have a treat in store for you. She's a terrific speaker. So thanks for having me.
Thank you for
Thanks,
coming.
Dr. S.
Bye.
So now we have Dr. Myers, who's going to give the back half of this. So she's mostly, and I correct me if I'm wrong, mostly going to talk about transplant and what transplant means for SDS.
Yes.
So,
Can I share my screen? Is that what I should?
Yes, please.
yes.
That.
So does that mean if they notice a change in the registry, they'd contact the patients themselves? Like you guys would contact them, or how does that work?
We would contact their physician. Can
Oh.
you see my screen?
I believe so. There we go.
There we go. Look at that. Okay.
Make it go to slideshow here. Whoop. Oh no. Now I can't see you. Can you guys see me?
You're fine. Yeah, we could see you. You're good.
Okay, great. Well, thank you for having me here this evening to talk about stem cell transplant or bone marrow transplant, both the same thing for Shwachman-Diamond syndrome. Just a quick outline of what I'm going to touch on today. I'll talk a little bit about what are stem cells, when we consider a transplant for SDS, some of the basic goals and principles of transplant, specifically historical outcomes for transplant for patients with Shwachman-Diamond syndrome, and then some newer transplant strategies for patients with SDS, and sort of finish it up with a few future directions. So starting with the basics, what are bone marrow hematopoietic stem cells? Well, it's in the name. They're located inside your bone marrow, which is in the large bones, mostly the large bones of your body. It's that red sort of fleshier part. And your bone marrow, as Akiko touched on, produces your blood, including red blood cells to carry oxygen, white blood cells to fight infection and to form your immune system, and platelets that help stop bleeding and form clots. Stem cells are really like seeds. When I talk to my patients who are going to transplant, I use the analogy of sort of a garden to describe this, but really stem cells can be transplanted and grow a whole new bone marrow in a different person over time. So,
Dr. Myers, I don't know if anything is supposed to be moving, but we're not seeing any of your slides. We're still just seeing the introductory slide.
Oh, that's a problem. Maybe I should share in a different way. Hold on. Let's see. Yeah.
Like I can see like I can see the screen where it was like going to start going and then it didn't ever go.
Let's try this. Okay, so now let me just.
There we go.
Let's try it like that.
There, it looks much better. Thank you.
Now, did you see it change?
Yes.
So we'll skip forward past these slides. So, as Dr. Shimamura mentioned, of course, we know that some patients in SDS may develop low blood counts, and sometimes this happens in all cell lines and is called bone marrow failure. And this can progress to full bone marrow failure or pancytopenia, or sometimes called aplastic anemia. And Akiko touched on this as well, that their main treatment for these low blood counts is supportive care in patients with SDS, which includes transfusions, GCSF to increase your neutrophil count, and sometimes antibiotic prophylaxis. But really, the definitive long-term cure for any bone marrow dysfunction in patients with Shwachman-Diamond syndrome is a stem cell transplant. So when do we consider transplant for patients with SDS? Patients with severely low blood counts. So not just mild anemia or thrombocytopenia, but really severe neutropenia with an ANC less than 500 that is not responsive to GCSF and has recurrent infections, or blood counts that require transfusions of either red blood cells or platelets. We also consider transplant for patients with high-risk cytogenetic abnormalities. So monosomy 7 would be an example of that. This does not include del20q or isochromosome 7 alone, which are very common in patients with SDS and are not considered in isolation to be a high-risk for progression to MDS or AML. And of course, we do offer transplant for patients with MDS or AML in Shwachman-Diamond syndrome. And Akiko spent a lot of time on our efforts on who to predict who is at higher risk for MDS or AML. So what is the goal of transplant for patients with SDS? Well, first, we want to normalize the blood counts. We want to take away that need for transfusion, make those neutrophil counts normal. We want to avoid something called graft rejection, which I'll talk about in a little bit. We want to achieve a full engraftment, which means a establishment of that new donor bone marrow where it's growing well and thriving in the patient. We want to minimize short and long-term side effects from the therapy, as well as minimize infection. We want to prevent something called graft versus host disease, which I'll also touch on. And then, of course, if there are any clones, MDS or leukemia, we want to destroy those so that they don't come back and cause trouble after transplant. Transplant is kind of a complicated decision to make. It's not always straightforward. There's a lot of moving pieces. And a couple of the things that we think about when we're deciding whether or not transplant is the right choice for a particular patient includes how healthy is that patient? How old are they? Do they have good organ function, meaning is their body strong enough to handle the therapy? How is their heart, their liver, their lungs? Do they have other things going on right now with their health, such as an active infection that might make the transplant process more difficult? Also, what sort of donor is available? Is there a matched sibling donor, or would we have to look for an unrelated donor? Sometimes stem cell source can also play a role in deciding whether or not to go to transplant. A bone marrow is generally a more preferred source, but we do use cord blood and peripheral blood on a regular basis for certain indications. And then finally, what kind of intensity of chemotherapy do we think that the patient needs for their transplant? So when we talk about matching, what does that mean? I just said that we know that the best match for a transplant, if it's available, is a patient's sibling or brother or sister. But what we're matching on are something called HLA, or human leukocyte antigens. And these are proteins on the surface of a cell that identify that cell to belong to that person's body. They're sort of like an ID badge you might wear to work. There's generally a 1 in 4 chance that any brother or sister will be an HLA match to each other. So that means that a lot of folks, 3 out of 4, do not have matched sibling donors. So at that time, we look for the unrelated donors, who are volunteers that have agreed to be tissue typed to help someone who needs a stem cell transplant in the future. It's really an amazing thing, sort of a terrific human feature that people are willing to help complete strangers. These tissue types are stored here in the United States by the National Marrow Donor Program in a large computer database. And then when a donor is needed, the patient's tissue type can be entered into the computer to see if there's a match. And this is called running a search. So searches are done over the internet and link all US and international transplant centers to over 38 million donors worldwide, and that's growing every day. Donors are anonymous. Patients don't know who the donor is until at least a year after transplant. And interestingly, cord blood does not have to be as well matched as bone marrow or peripheral blood. And so some patients in whom an unrelated donor is not available can sometimes find a cord blood donor match. And there are almost 800,000 cord blood units frozen and available worldwide. So I mentioned there are different types of stem cells, and this is just a quick slide to show you how they're collected. When patients' donor's marrow is collected, it is collected from the hip bone, very similar to how our patients get their bone marrow aspirates and biopsies. It's done in the operating room under anesthesia. Peripheral blood stem cells are actually stimulated with GCSF in the donor and then collected through IVs via a special apheresis machine. And then, of course, cord blood units are collected at birth. So the basic principles of transplantation are fairly simple and straightforward. A patient is given intensive chemotherapy, which we call conditioning or preparative regimens, and this chemotherapy destroys abnormal marrow. It decreases the immune system and makes room for healthy stem cells from the donor to grow. These stem cells are infused into the patient through the central line and find their way into the bone marrow space. And really, within about 4 to 6 hours, they've settled down in that bone marrow and they begin to attach, grow, and divide. Patients are also given medications called immune suppression, and this helps prevent graft rejection and graft versus host disease. But because of this immune suppression, it takes a long time to grow a normal immune system. So on average, it takes about a year after transplant to have a fully normal immune system. So I've mentioned graft rejection and graft versus host disease a few times, so I wanted to just touch on those briefly. Graft rejection is when a patient's immune system recognizes the donor's stem cells as foreign and rejects it. And then graft versus host disease is sort of the opposite, when the donor stem cells recognize the patient as foreign, and as the job of your immune system is to attack things it doesn't recognize, it also attacks. Obviously, neither of these things are things we want to happen, and so there are adjustments that can be made to the treatment plan to try to decrease the risk of either of these. This also touches on the fact that different transplants have different levels of risk, and so each person is a bit individual. Matched sibling transplant, as we said, are often less risk than matched, unrelated, or mismatched transplants. Stem cell source can also play a role, and then the level of intensity of the conditioning regimen, with myeloablative or full intensity chemotherapy coming with a higher risk. So switching to transplant specific for patients with SDS, historically, the full myeloablative treatment regimens had very poor outcomes. There was high incidence of graft failure and graft rejection, and transplant-related toxicity and mortality was quite high, especially toxicity to the heart, liver, and lungs. When outcomes are poor in rare diseases, often collaboration is critical in improving outcomes and moving care forward. And so this is just an example of changes in outcomes for transplant for a different rare disease, Fanconi anemia, which is also a bone marrow failure disorder, where patients came for clinical trials at expert centers. And this shows the addition of fludarabine, which is a particular chemotherapy agent, to the transplant regimens for these patients. You can see that there's significant improvement for both matched sibling transplants on the left and matched unrelated transplants on the right after the addition of fludarabine. Actually, these are kind of old curves. There have been continued clinical trials and more improvement in transplant outcomes. So transplant outcomes for patients with SDS have also improved. These are two articles that came out this year, one that I worked on with the CIBMTR here in the United States and another from the European group. And this curve shows that patients with primary SDS, which in this study means bone marrow failure as the indication for transplant, had significantly improved outcomes from historic treatments. Now, we believe that this is likely due to the increased use of reduced intensity transplant or lower intensity chemotherapy, but neither of these studies had the statistical power to prove that because the numbers were low, too low in both studies. And you can see, as Akiko touched on, that patients with MDS and AML had outcomes that were not as good. Akiko already talked about this work published through the registry, so I'm just going to touch briefly on it to say that patients with MDS have better outcomes than those with AML, although still there's room for a lot of improvement. and also to put a plug in, as Akiko said, for surveillance marrows, because you can see there on the far right that patients with surveillance marrows in the purple had improved outcomes compared to those without surveillance marrows in the green. So all this sort of highlights that the decision to undergo transplant should be made with a team that is experienced in Shwachman-Diamond syndrome. Patients with SDS have an increased sensitivity to intensive chemotherapy regimens, especially those containing cyclophosphamide, or otherwise known as Cytoxan, or radiation. So the goal in patients with SDS is really to use a regimen that does not have these high-risk organ toxicities, especially being sensitive to the liver, heart, and lungs. So I'm going to talk about two approaches for transplant in SDS. One is a reduced intensity approach using Campath, fludarabine, and melphalan, and I'll touch on the Cincinnati experience there. And then I'll talk about a reduced toxicity approach using triosulfan, fludarabine, and ATG. So Campath is an immunosuppressive antibody that wipes out the cells that are responsible for graft rejection and helps reduce the risk of graft versus host disease. Fludarabine is an immunosuppressive chemotherapy drug that helps prevent graft rejection, and you'll remember that that's the drug that helped improve outcomes in patients with Fanconi anemia as well. Melphalan is a stronger chemotherapy drug that is somewhat similar to Cytoxan, but does not have the same cardiac or pulmonary toxicity. And so the bottom line with this regimen is that we were able to remove radiation and Cytoxan. And so this is a report from a few years back now about our experience. This report covers 7 patients with SDS, all with SBDS mutations, about half of which had a matched sibling transplant, and about half of them had their transplant for low blood counts, although several of them did have abnormal clones. 2 had MDS and 1 had leukemia. All of these patients engrafted rapidly, did not have significant graft versus host disease, and did not have any cardiac or pulmonary toxicity. 6 of the 7 patients are now surviving from this original publication. It's now been a while, as you can tell from the numbers there. And the 1 patient who came to transplant with leukemia did unfortunately relapse about a year post-transplant and passed away of her leukemia. Outcomes with this regimen continue to be very good, although they're not published, so I could not share them with you here today. Moving on to triosulfan, this is a drug widely used in Europe, but not FDA approved here in the United States, so it can only be used under IND in a research study. It is a chemotherapy that is used in both solid tumors and transplant for malignant and non-malignant disease. As I mentioned, it's reduced toxicity, which means it is still myeloablative, but less toxic. And the results are quite encouraging. There is successful engraftment and decreased toxicity with less organ damage and improved survival. And I should mention that these slides are courtesy of Dr. Lori Burrows, who was the PI of the clinical trial for bone marrow failure patients using this drug, triosulfan. This trial had 23 patients, 4 of whom had Shwachman-Diamond syndrome. And the conditioning regimen is similar to what I just showed you with the reduced intensity regimen, using fludarabine as well, triosulfan, and then rabbit ATG, which is an antibody that works in a similar way to the Campath that I previously described. Outcomes for this trial were excellent, with overall survival of 96%, and the median follow-up for these patients is 2 years. So where do we go from here? We are looking for, Medic, the company that makes triosulfan, is looking for FDA approval here in the United States. And there is a new national clinical trial, which we're super excited about, through the Bone Marrow Transplant Clinical Trials Network for patients with bone marrow failure syndromes, including patients with SDS. We hope that this trial will open this winter. It's slowed down a bit due to the COVID situation, but this trial is being led by Dr. Lori Burrows, and Akiko Shimamura and I are both part of the protocol team. And then we also have a clinical trial, hopefully in development, for MDS and AML in Shwachman-Diamond syndrome, as well as other marrow failure syndromes. I'd like to thank our patients and families, as well as, of course, the registry participants, and then Akiko Shimamura in Boston, who's so fabulous, as well as both of our research teams. And I'm happy to take questions.
Oops. Give me 1 second. We're going to take down your slides, if that's okay. So one of the questions
I will admit, I am. My chair made a noise. I can't, and then I tried to stop moving so my chair would stop making the noise because I didn't want you to. Can you ask your question again, Orva? Sorry.
When should a patient be typed to see if they have matches?
Oh, sure. That's an excellent question. So, that is not it's not the same answer for everybody. It's never wrong to HLA type a patient. I think that if you have an inherited bone marrow failure syndrome like Shwachman-Diamond syndrome, it is always good to know your options. So we generally type our patients when we first meet them. I see patients who have SDS that don't need a transplant as well as those who do. So I generally type many of my patients when I first meet them, but not everybody. But if you are somebody who is having falling blood counts or anything concerning in your bone marrow, then certainly that is an indication to have typing. Or if you are a non-Caucasian, because the bone marrow registry actually has fewer donors that are not Caucasian. And so oftentimes, and actually for genetic reasons, oftentimes donor searches are more difficult in other racial backgrounds. And so sometimes they can take more time. So I usually type patients earlier to know whether or not I am going to need to have more lead time to find a donor, because genetically some people have very common tissue types and there are thousands of donors available, and then there are patients that are unique and they're the only one. And so and ethnicity and racial background can sometimes play a role in how likely that is. Although certainly I've had Caucasian patients who've had trouble finding donors in the registry as well, so that's not a universal statement.
Interesting. That's really good to know.
If there's a sibling in the family, would you start with typing the patient and then see if the sibling matches that type, or and is that done? How would someone go about that? Would they ask their one hematologist for both things?
Yeah, so anybody can send tissue typing, although the level of tissue typing is different. So you can order sort of high level tissue typing that is just sort of a screen, or you can order more intense tissue typing that we would actually use for the transplant itself. I would say that, or asking your hematologist is fine. Or if you're seeing a bone marrow transplant doctor, then they can send that tissue typing too. But usually I do start with the patient. If I'm not thinking the patient needs transplant soon, then I only type the patient and sort of type family members later as needed.
Can siblings?
Interesting. Joan had asked what. No, go ahead.
Can siblings that carry the SDS gene donate if they are a match?
You mean carriers?
Yeah.
Carriers. Have one. Yes. Carriers of the SDS gene can donate.
Okay.
Joan had asked what, and I'm gonna slaughter this name probably. What do you think about as
azacitidine? Azacitidine, yes. So azacitidine is a medication that is often used in patients with yes, and sometimes with leukemia as well. It is a good medicine. I've used it in several different patients. And it is generally sort of a temporizing treatment as a step towards transplant. And so, occasionally it is used after transplant in patients that you are worried are at high risk for relapse.
Interesting.
Yeah, it is not generally thought to be a curative therapy, but certainly for patients where you need time to find that donor, it can be a good medicine to sort of buy you that time. Or in patients who are not interested in pursuing a transplant for various reasons, or for whom transplant is not an option, that can be something that can be potentially therapeutic for a time.
We had a couple of questions that came in on the backside via the support page, and then a couple of messages. One of them was, are you seeing a higher incidence or a continued high incidence of the 20q deletion in SDS patients?
I would not say we're seeing a higher incidence, but we definitely still see it. And it's present in a lot of patients, yes.
And then another question that came through was that their doctor had, before they started them on GCSF therapy, they ran some type of a cancer risk panel, and something red flagged on there that they should not be given GCSF. Is that something that is fairly common among SDS patients, that they should get that ran?
That is not something I would have standardly run on a patient. Generally, before starting GCSF on my patients, I do a bone marrow, and run the standard surveillance testing that we run, including the sequencing that Akiko mentioned, that should identify any high risk features that would not make you want to start GCSF. Yeah. And
That
so
would make sense. We had to get a marrow before we started.
Right. I don't know if that test that whoever was asking about might have been the sequencing test that I mentioned.
Might have been, because it sounded fairly similar. It was just something that I never thought of in my head, but I never thought of it because it was just done for us without having to think about it.
Now I'm curious if that's what RJ had done, because we were told he cannot get GCSF. So now I'm wondering.
Now you know. I don't see any more questions that have come in, but again, I know, just like Dr. S had said, and then like the past shows, if we get any questions, if people think of something later on, please email them to us. We'll forward it. Please email the registry. Please, there's always ways to stay in contact, especially during a pandemic.
Yes, absolutely. We would be happy to talk to anybody who wants to reach out to the registry. We're always happy to talk, both Akiko and I.
I have one last question for you. What if the HEMONC does not agree with a yearly bone marrow biopsy and tries to space them out, since previous biopsies have been normal?
I second this question.
Have them call us.
Okay.
I am always happy to talk to other physicians and discuss the data. The new paper, that's actually one of the reasons that we worked so hard to get this retrospective data from the Lancet, in the Lancet Hematology paper, looking at surveillance, as well as this new paper in collaboration with Coleman Lindsley and Melissa Kennedy with Akiko. Those two papers combined show the importance of surveillance. And really, your question is a very common one, because we hear that a lot. It is important, and I'm happy to chat with any physician that wants to speak with me.
Are patients or their parents able to access those papers to take to the doctors, or the articles?
Yeah, absolutely. And if you can't get those papers, ask the registry. We're happy to share.
That's awesome.
Awesome. I think we are only 9 minutes over, and I think that's a new record.
Yeah.
Hot Mess Sunday 1. We did it.
Happy Sunday. We win. Thank you again for joining us, Dr. Myers and Dr. S, who's no longer on the screen, but we appreciate both of you for all the tireless work you put in for this disease and our kids and our patients and everyone. And so we really do appreciate having you on and sharing this wealth of knowledge. And I'm sure this will not be the last time we see you guys.
Exactly. Yeah, thank you.
We're happy to do it. Yeah.
Awesome.
Just a little side note, Savannah Lillywhite would like to say hi to you guys and let you guys know that Lincoln's doing amazing.
Oh yeah, that was way up there.
Yeah,
I got distracted.
Well, thank you.
Yes, thank you very much. Everyone have a great night. Thanks for joining us on this hot mess edition of SDSF Live with Orva and Michelle. And we hope we all made it through in one piece. Have a good night, everybody.
Bye.